invite Dr. Simar to give a talk. Present his case. He's a very passionate pediatric surgeon as well as a great person.
Thank you. Thank you so much, ma'am, for the kind introduction. So I'll be presenting a case of Norries disease that again borders onto the FEVR spectrum. So this was a 7-month-old term child brought by parents for leukocoria noticed for the last 1 month. He was a full-term normal vaginal delivery, no NICU stay, no supplemental oxygen, and no in the perinatal period. So this was the presentation. You can see the right eye on the this side and the left eye. The left eye had the fibrotic membranes attaching right behind the lens, and we did not have much view. It was smaller in size also. And the right eye, we could see this kind of focally attaching at one place in the lens, and we could see some amount of retina over here that you can see over there. So our differential diagnosis at that point of time was congenital FEVR, Norries, or atypical ROP. So this was the examination under anesthesia for both the eyes. You can see the right and the left eye. Left eye almost like stage 5 ROP, very shallow AC, and synecdoche. And the right eye, you can see that the pupil was dilating. There was some synecdoche, but it was well dilating, and we could see that thing completely coming towards the lens. So we decided to go ahead with surgery for the right eye, and I'll quickly go through the surgery. Once we entered the eye, you can see this coming very interiorly. ROP cases, this stalk that is attaching to the crystalline lens, we can dissect it usually easily. It's not very firm, not very fibrotic, and maybe we are going in a little early also, and then this was 7 months old. So this was very fibrotic, very taut, very difficult to dissect. And, I'm not just pulling it, I'm using my cutter, but it took some time to dissect. Just trying to salvage the lens of that small bit attached to the crystalline lens. Then we cleared out the vitreous hemorrhage, which was very dense interiorly. You can see the retina kind of a twisted kind of fold. Couldn't really see the disc or any vasculature in the case. But we still wanted to try and clear the media and give the child whatever best chance that he could have. Then again, this bleed was so tightly adherent to the underlying retina that the differentiation of planes was a little difficult even when coming from both the sides. You can see the gliotic retina that we could see, almost like the retina had not formed, which is sometimes described in Norries disease. So once we did this, we completed the laser all around, and just finished the case with a fluid injection. So this was the fundus picture post-op, 6 weeks. You can see, we could see this retina falling back, some amount of exudation subretinal. This was the part that was left attached to the crystalline lens. And this was the posterior pole that the child had. He could fix and follow light, but we don't know what other visual potential the child might have. The genetics showed a pathogenic variant in the NDP gene, hemizygous. And when we evaluated the mother, you can see the supranumerary vessels coming out of the optic disc, very typical for FEVR. And the angiogram also showed a stage 2 FEVR in both the eyes, which was subsequently lasered. And the genetics proved the presence of heterozygous condition in the sibling also, which was 3 years old but doesn't show any signs of FEVR in that case. Thank you. Any questions or opinions, ma'am?
Recently there was a baby in a normal hospital in Bangalore, and they are doing the red glow, and the report said red glow failed on day 1 of life. And then I said to the parents what happened. They said at one day, they said there's no glow, you come after 2 weeks, then senior will see you. Then senior has seen and written red glow fail, and then referred to the eye specialist in the city in Bangalore. Then in the eye specialist, they have taken a fundus picture. One eye is leukocoria, no view. Other eye almost looking like this, like total vitreous hemorrhage, but I could see in that fundus picture little disc. and they have written, no, this is Norries or FAVR and no treatment advised, and told that the eye is going to be blind. And then they reached me after 2 months. By that time, both eyes are sort of gone. So this fulminant type of FAVR, which occurs at birth, is not very well described in literature because they don't reach us on time to see this picture.
Yes.
But this is exactly what we want to do. That if you see, even if you see little stalk, even if you see retina is dysplastic, at least go in. Sometimes you may have to use Avastin also. Go in and do that vitrectomy. You may salvage little bit of formed retina, and at least you save the eye from going into the eyes, and some part of retina may attach, and that part may be functioning. Okay, so I think excellent surgery. We should attempt surgery in all these eyes as quickly as possible, and not make them go from one place to another.
Right. Thank you so much, ma'am. I invite Professor Raman sir now, my mentor, who will be.
That lot is not more than 6 patients in my whole career. So I'm so happy because I don't want to see any child with pain actually. So I've not operated more than 6 patients. So Dr. Jagatram has a very long series, but I've been doing this PHP. We work with him. So I was managing his posterior pole PPP. You can play it. Kar diya? Yeah. Oh, sorry.
Yeah, just play this.
आप play कर दो वहाँ से. Yeah, I'll do it. Sorry. Oh God.
You can start the video again, please.
I'll do it. Are you okay, na?
Yes, I'm fine, sir. Thank you.
So this was a patient had a white cataract and a eccentric kind of this thing. So after that, I put in an AC maintainer, and Dr. Jagatram was planned IOL for him. I pursued no IOL for him. So this is what then I took over, and then we just this is how we go. That once you have area is clear, we thankfully this patient didn't have much of a vascularization in the capsular area or in the ciliary body was good. So all he had was a eccentric stalk which was going deep down to the optic disc. And this is how these are the cartoons given by Michael Tracy group, that there's a cloak kind of thing. Retina is getting cloak, so from all the sides. This is how this is how the problem starts. So this PHPV, the persistent fetal vasculature is surrounded all side by the retina, and this is where the problem is, and this is where the retina surgeon has to come to play to salvage whatever they can. So this is one of my most aggressive surgery where I did use this first Canacot to take care of all the hyaloid in this patient. And again, like in a usual vitrectomy, you have to do these process very meticulously. Kids' hyaloid is not easy to remove. There is always some part of the retina which is between the attached and the cloaked retina, so that appears little lifted. So you have to take care that you don't create a RD there or a break there. So you have to go very, very slowly, and these surgeries are shown in 4 minutes. Might have taken me 2.5 or 3 hours there on sitting on this case under GA. This was a 4-year-old boy. And then I said most aggressive case, so I did ILM peeling also in this case. I think I may have gone to some VRSI and saw some Egyptians doing this surgery, so I did some ILM peeling in this patient. I did because I thought that it will ensure that I have taken care of the hyaloid. So you can see that ILM has been peeled all around, and this was done temporally also and nasally also. And again, it has to be done under utmost care, because we are not planning to do any iatrogenic harm in these patients, because causing a break in these eyes would lead to a tamponade or this thing. And this was done. You can see how the fetal vasculature is cloaked from the retina from all sides. This fold was there all the time, and all we have to do is just to take out this fibrous tissue and bring it to the top, and then you can cut it. This is what is being done with the see. I have shifted to the bimanual surgery also. I'm using chandelier also in this patient. So yeah, sorry. So once all the fibrous tissue reaches to the top, then it's the time to cut the finally the trim the stalk to the max, so that here you have to take care you don't cut the retina there again, because there is sometimes some bleed is there, which is taken care by just increasing the pressure of the eye. And this again, it is being done bimanually. You can see the forceps and a scissor in my hand, and this is followed by again, because I have not caused any iatrogenic injury, and just do a fluid exchange and leave these eyes. And these are again very 3 by 60 or 4 by 60 vision, and they need squint surgeries, but these are precious eyes, sometimes you have to operate them. You always give them a chance in these eyes actually.